Ora si registrerà la conferenza.
Ok, puoi iniziare a parlare.
Ok, buonasera a tutti, benvenuti ai nostri ospiti, benvenuti ai soci Siagascot. Per me è un grandissimo piacere stasera poter condurre questo evento che vede come protagonisti due grandi chirurghi, due professionisti che sono stati molto importanti per la mia carriera professionale e penso anche per quella di molti altri. Sicuramente non hanno bisogno di presentazioni in quanto, diciamo, la loro fama li precede. Quindi do il benvenuto al dottor Lioi e al professor Van Dijk di Amsterdam. Un grazie per aver accettato l'invito a questa serata e un grazie soprattutto a Siagascot che ci consente di vivere queste esperienze di confronto e ci mette, diciamo, nelle condizioni per poter migliorare le nostre conoscenze. So, good evening everyone. It's a special night for me. I'm very excited because this evening I have the opportunity to interview two of my teachers that they helped me in improving in my surgical skills and knowledge in ankle scopes. It's a very pleasure introducing Professor Van Dijk. Is an opinion leader in the treatment of the ankle pathology from Amsterdam, and Dr. Lioi from Forli is the best teacher for me. I love him. And thank you, Prof. Thank you, Dr. Lioi, for accepting the invitation for this interview. Repeat, a real honor for me. Thank you from Siagascot board that gave me the opportunity to lead this interview. I attended many times the Professor Van Dijk ward. The first time was in 2008, then I came back in 2009, 10, and 12. And I participate to his interesting ankle-foot courses at the ankle-foot platform. And from this experience, I took home many useful advices that I'm using during my daily practice in ankle scope. So very important for my professional growth. And thank you again. And I give the word to you for greetings. Please. Professor Van Dijk.
Well, thank you very much, Alberto, and also Francesco for inviting me for this interview. I think it's a really wonderful idea of Siagascot to have these interviews. I was not aware in Holland we don't have them, but I think it's important to recognize your teachers, and that's what I always do. So. Now being regarded as your teacher, as you say, that makes me very humble, and thank you very much for having the honor to be invited here for this interview together with Francesco.
Dottor Lioi.
Buonasera a tutti. Parlo in italiano per salutare tutti, ma il mio saluto va a tutti voi. Ho voluto che il professor Van Dijk fosse stasera con noi perché è stato il mio maestro ed è il maestro, direi, di tutti noi. Per cui è veramente un onore per me stasera essere insieme ad Alberto e a Nick. I want to translate only two words for Nick. That is an honor for me to have you this night because you are my teacher, my professor, my leader in the field of the ankle, and so I really wanted to have you this evening to speak with us about ankle and our experiences. and I have the honor to have you and to thank you for everything that you have give me in many years. Thank you, Nick.
Thank you, Professor. So we can start. So Siagasco present, meet the professor. And sorry, Professor Van Dijk, I use Italian to present 2 or 3 slides and then we turn in English. Diciamo era un pochino il 2007, ho identificato il 2007 quando iniziai questa mia ricerca matta e disperatissima, quindi faccio una citazione leopardiana per quanto riguarda la ricerca come diceva il decadentista Rimbaud, il poeta Abate per me era il chirurgo, cioè colui che era l'interprete appunto privilegiato dei profondi segreti, non tanto della natura, ma in questo caso della caviglia. Quindi iniziai questo lungo percorso in giro per il mondo, partendo dalla California, al professor Van Dijk in Amsterdam, al professor Kennedy in New York e al professor Myerson in Baltimore, e per cercare appunto di formarmi e di migliorare quelle che erano le mie esperienze, le mie skills sostanzialmente. Nel gennaio 2008 fu la mia prima esperienza alla MC, esperienza molto fredda perché andavo in gennaio, era molto freddo e mi ricordo sempre questo trenino che prendevo tutte le mattine per andare dal professore. This is the train that I took when from the Amsterdam professor. I went from the center of Amsterdam to AFC. It was very cold because I attended your work during the January, so winter, so very cold. And poi diciamo cercai in Italia di trovare qualcuno di più vicino, e come non dimenticare il professor Raolzini di Cotignola, che mi ospitò più volte, ma diciamo e che lo salutiamo tutti quanti in maniera molto affettuosa, però diciamo l'amore nacque nel 2009 con il dottor Lioi, che mi fece di tutto per diventare un suo discente in quel cadaver lab, e lui diciamo iniziò a farmi muovere le mani. Quindi da Forlì ad Amsterdam con furore, ecco perché abbiamo voluto nominarla così questa serata. E una cosa avevamo in comune, one thing we have in common, me and Dr. Lioi, the master, Professor Van Dijk, number 1, and stop. So now we start with a question time. And yes, I used last night I was watching the movie of Woody Allen, and I had a brilliant idea, because when I read the title of the movie, it was everything you always wanted to know about sex, but were afraid to ask. So I changed sex with the ankle, and it's very funny. And so the first step, I divided my interview in 4 steps. So we started from the beginning until the future. So at the beginning, the first question is, generally surgeons prefer to treat hip, knee, shoulder pathologies. But I want to know, why did you choose to treat the ankle joint pathologies? And the second question, I'm very curious to know if you tell me something about your training, your learning curve, and about your training. Who was your trainer, please?
So thank you very much, Alberto, for the question. And as to the first question, the reason for me to start with ankles, basically there is 2 events that were important for me. And the first one had to do with Marco van Basten. I guess you remember Marco van Basten playing in Milan for 8 years, and he had to finish his career in 1995 due to a destroyed ankle. But the original injury was in December 86. And I saw it on the television. I was watching the television. I saw the accident. And 1 week later, he was visiting my chief, Professor René Marti. And I was still a resident, and I had to make his notes. So I was there investigating his ankle, and his ankle was swollen. There was discoloration, there was pain, and to me it didn't feel very stable. But there was no diagnosis made. There was no proper treatment given. So I was puzzled, and because that was apparently how we treated sprained ankles at that time. But it triggered my interest to start research, which I did, and it led to my thesis a few years later on. The title of the thesis was on diagnostic strategies in ankle sprain. So that was one. And the other thing was it had to do with one of my teachers, Professor Thomassen. Thomassen was an orthopedic surgeon from Denmark, and he was at that time in the 80s the only surgeon that was specialized in treatment of ballet dancers. So he visited.
Treatment I don't understand. Treatment.
The treatment of ballet dancers. Ballet.
Okay. Oh, sorry. Okay. Thank you.
Yeah, ballet dancers. And so he visited the National Ballet twice a year, and I was invited to assist him during these visits. And one of his strong messages was to try to avoid by all means to do surgery. So he was a very conservative orthopedic surgeon, because he said, if you do surgery, then the scar itself will lead to a range of motion deficit, and a ballet dancer needs all the range of motion. So don't operate on ankles, on the big toe, because it is the end of the career, the operation itself. So that triggered me to develop techniques like the anterior and posterior ankle arthroscopy and the tendoscopy and the endoscopic calcaneoplasty, because I thought, if I can do it with, my teacher says I cannot do it, so I will not do it. But if I can do it with arthroscopy, maybe it will not. It will be beneficial for the ballet dancers. So that was the two reasons for me to focus on ankle.
Sorry, Prof. Did you start from the knee before or not? Only ankle?
Yes. No, of course. I did elbow, I did shoulder, I did hip, I did everything. I also did total hips, I did total knees, I did all orthopedics, of course. But my chief did not do arthroscopy, and arthroscopy was just starting in the 80s, the 70s, 80s with the knee, and I thought, I can use the scope maybe for the big toe. I can maybe use it for the ankle. So that is how it evolved. But I did everything. And your second question about my training and who was my teacher and my trainer. Well, in fact, I had several mentors and trainers, and maybe you can say that every patient, I learned from all my patients, not all my patients, but a lot of patients. If the feedback you get from the patient and from your surgery, that is a big source of inspiration. But my residency, my trainer was Professor René Marti, and he was from St. Gallen in Switzerland, and he was one of the big names in the AO. And his teachers were Maurice Müller and Hardy Weber, also from St. Gallen, from the AO school. So I was very well trained in traumatology and post-traumatic problems. So I did a lot of osteotomies in the lower leg, in the upper leg. And his mantra of my Professor René Marti, was that good quality is your best advertisement, meaning that if your patients are satisfied, then they will advertise for you. And that's how I always have been dealing with my patients. Always try the best for each of your patients. But also in ESCA, I had mentors and like Lars Engebretsen and Neil Thomas. But the first one was Giancarlo Pudu from Rome, and he was the one who was apparently believing in me, and he pushed me forward in ESCA. And I don't think that I would have made my steps to be president of ESCA without his mentorship in those early days. And what's interesting, what I learned from him, that it's very difficult to deal with someone who has charisma, and he has a lot of charisma. So I always was wondering if he even prepared the meetings, but with his charisma, he was overpowering all arguments, all logic, and all sense. So from that I learned, well, 99% of us don't have charisma like he had, and like my professor René Marti had. So if you don't have it, like I don't have it, and 99% of us don't have it, then you always have to work hard and to prepare yourself 100% in order to make your point and to achieve your goal. So he was a very good teacher for me in that sense, that I had to work.
Yeah, thank you. Dr. Lloyd? Dottor Lloyd?
Ecco,
Ecco.
non riuscivo ad attivare l'audio. These are wonderful words from Nick, because he has a great charisma, and I remember in many meeting of the group, of our group, on the ankle, that when Nick spoke, everything it's okay, it's everything it's right. And my story began in the 80s. I remember one of the first Congress of the GIA, that was the group of Italian arthroscopists. It was before the SIA, before the Society of Italian arthroscopists. I remember a congress of Giuliano Cerulli in Perugia, and it was one of the first arthroscopists of the ankle in Italy, and I was fascinated by this joint, and from there I started to learn something, to study more, to study a lot of things. And then also for me, as for you, Alberto, Raul Zini, that is a great friend of mine, was I think my first teacher on the surgery of the arthroscopy, of ankle arthroscopy. Now I am much more clever than Raul. We many times we speak about it, but Raul was my first Italian teacher, and he was in my hospital for 2 or 3 times, and we operated some ankles that for me were something of trouble to operate, and then there was the jump, the big jump in Amsterdam, when I, in the 90s, I was in Amsterdam with Nick, and I remember I have many memories of the first travel in Amsterdam, and one of my memory was like yours, Alberto. I was the first time at 6 o'clock in the Academisch Medienzentrum with the train, and during the night before the dawn, and because it was January also for me in January, and I remember the ducks that were walking on the water, and I didn't think what was this miracle. And then after 5 minutes, I realized that the water was a floor of ice, and so the ducks walked on the ice. And this is my first impression of Amsterdam and of AMC at Amsterdam. And then there was I met Nick, that was from the beginning so kindly and so friendly, and I remember that tell me something that I will explain during my conversation, following my conversation.
I agree with you. I remember he was very open, very gentleman. Yeah, I remember. He discussed every case with the guys. He's a resident, very really enthusiastic experience. Thank you so much for the first question, for two questions. So keep going with the second question. Before becoming an idol, for me, you are an idol. Do you remember your first steps? But I'm very curious about your first ankle scopes. Did you got any difficulties? I imagine yes. But I'm very curious, Professor Van Dijk, your first ankle scopes.
Yes, so Alberto, I just told you about Marco van Basten and about the ballet dancers, and that I wanted to do the scopes on ankles. So of course I was studying the literature, and in the 80s arthroscopy was done with distraction, with an external fixator. There was a book from Jim Gould from Milwaukee, and he described very well how it should be done. So so I studied the literature, and I started doing ankle arthroscopies with the external fixator. But I found it very difficult. I found it very time consuming, and I'm a bit claustrophobic. So if it is, everything is fixed and you're in a narrow environment, but you cannot move, narrow space, I decided that I had to visit Jim Gould because I thought I do it wrong. So I arranged a fellowship with Jim Gould, and I went to the United States. And I must say, he was extremely kind. The Americans are nice hosts. You were both you and Francesco were very kind on how I treated you in AMC, but it doesn't compare to how you are treated in US. It is fantastic. But the ankle arthroscopies that I saw him do, it was very disappointing because it took him a few hours for an ankle arthroscopy. It was clumsy. The instrument broke at some point in time. I was getting nervous when I saw it. I thought, well, if this is the big master doing an ankle arthroscopy like this, it is not very easy. So when I came back, I decided to go to the cadaver lab and to develop my own own technique, which I found without the distraction, which I found much more easy, quicker, more efficient. And that is the technique that, that basically we still perform up to today. There are still some Americans who use the distraction because, of course, the fixed distraction has, with the external fixator, has now become another distractor. And Richard Fergal still promotes this fixed distraction, but as the literature shows, the neurologic complications are 3 times higher. You cannot do ligament reconstruction, so I'm sure that the United States will follow what in the rest of the world is done with arthroscopy without distraction.
Okay. And but I remember when I visited Professor Ferkel in 2008, he used your technique, Professor Van Dijk, non-external fixator. Probably he changed after your studies, probably.
But when you read the literature, he still promotes the distraction. So that's funny. I'm happy with your remark that he does. I know that he also does, and his son, he visited also me. Very nice guy, and he does the posterior arthroscopy. And Richard, I don't know, but I didn't know that he didn't. That's good news.
I don't understand. So.
Oh, that's good news that he doesn't use the distraction any longer. I didn't know that. That's good.
Yeah. So, dottor Lioi, le sue prime artroscopie di caviglia, your first endoscopes, you remember?
Yep, I remember especially a point, a mark point, that are a period, excuse me, before Nick and after Nick on Dijk. It's a frontier. My first travel in Amsterdam was really for me a change of horizon on this kind of pathology, because I saw many things. I was studying a lot of paper of Professor Van Dijk before my first journey in Amsterdam, and I think I read perhaps every paper written by Professor Van Dijk. But when I was there, I remember the first morning I was there. Excuse me. I was there for one thing. I read some papers about tendoscopy, and I was very curious because I thought that ankle arthroscopy for me was yes, just a good technique, and I was curious about tendoscopy. So I went to Amsterdam with a final point to understand how to perform tendoscopies. It was not my stay in Amsterdam was another thing. I think that the first morning in the clinic, Nick told me a thing. Oh, I want to tell you a trick about posterior approach of the ankle. For me, was a strange thing because I learned that in 19 in 1998, I don't remember exactly, it was impossible to perform a posterior arthroscopy. And Nick told me this thing. From that point on, my horizons changed about the ankle. So I saw the technique without distraction. So I saw a particular technique of anterior arthroscopy, different from my technique. I saw the wonderful posterior arthroscopy. I saw also 2 or 3 tendoscopy, but was not the best thing I saw there. And so my word of surgeon, of arthroscopy, of our arthroscopist, changed, really changed my way of think and my way of doing. So this is a start point of my career on the ankle. And the journey began since that moment, and I think it is not finished yet. But I remember that morning, really with a vivid memory, real vivid memory. And that today, in my surgery reports, nowadays about posterior arthroscopy, I still write following the technique described by Van Dijk. In every my surgery report, this is a report that I do, because my career began in Amsterdam in 19 with Nick.
Yeah. Thank you so much.
Thank you very much, Francesco. Maybe just to, because I feel very humble with all these words that both of you are saying, and what I always feel that I feel always a big responsibility on my shoulders, because with everyone that is visiting and all the techniques that you that I with my team invented, you never know how it will work out, and if it will be if surgeons will be making use of it, and if the patients will benefit from it. So and most surgeons, when they visit, they come to see techniques, and as you remember probably, I always tell all my residents and all the visitors, it is not just about the technique. If you want to have a good result, you have a proper diagnosis. You have to listen to the patient. The history taking is most important. The physical examination is most important. And I felt always very lucky that that you, for example, were visiting me, and that I could give you that message, which for me was even more important than showing the techniques. But to make a proper diagnosis, that is the key to success. I'm very humble that I've been able to give you that message, and
I use these words, Prof, in many congress. I remember during your surgery, every day you told to the resident, remember, guys, a proper diagnosis is fundamental for your patient. I remember, and I wrote this these words on my brain, and I use in the Congress. This is fundamental. So I have learned something. I have taught something from your during my residence to your hospital, that is important to improve daily your skills. Is fundamental for a professional growth. So experience, ability, competence, and knowledge is fundamental. So the next question is, how important were your first mistakes for your professional growth, and when the trouble become an opportunity in your cases?
Like I was just saying, as a resident, you learn the operative techniques from your teacher, from your professor, from your master, and ideally, your teacher will protect you from making mistakes. And basically, later on, as a craftsman, you cannot afford to make mistakes. And I believe the main mistakes, and it comes also down to what I was just saying, the proper diagnosis, but the main mistakes are in communication. And my mantra is listen to the patient is always right. Meaning, patient will tell you the diagnosis. If you listen, the history taking, the patient will tell you the diagnosis. So if you have a proper diagnosis, the rest will follow. History taking, physical examination, treat the patient, not the MRI. Nowadays, we treat the MRI. Patient comes with the MRI. I see there's a cartilage lesion, we're going to treat it. It comes from the knee. In the knee, the MRI gives the diagnosis, and the physical examination is hardly practiced any longer. And it's also because the patient, he says, yeah, but I see there is this meniscal damage. So shouldn't it be treated? Well, you investigate, and there it's not the meniscus that is the problem. Femoral pain or whatever. And that's for the ankle. It is the same. So I think you have to take your patient serious. I think that is the most important.
Yeah.
Yes, I have two great teachers that taught me to hear what the patient say. The first one was Renato Viola, that many of that you, Alberto, and many Italian surgeon on the knee knows very well. He was the first to teach me to hear what the patient say, and the second one was Nick, and in the clinic in the afternoon after the surgery room, I followed him in every point of his visit, or the way of speaking with the patient, the way of pay attention to what he says. And these two teachers for the knee and for the ankle are for me the best the best teacher in my life, in my particular field of surgery. And so I think, like like Nick, that what the patients say to you, not also before the surgery, but also after the surgery, and the controls are very important to elevate your skills and to sometimes have some changes in your activity, because this is the real result of our surgery. So we have to ask the patient, how are you? What do you think? Have you troubles? Tell me everything. And this is what I think.
Yeah. Thank you. And another very quick question for the young guys who want to start with an endoscope, an advice about how overcome the fears to start in this practice.
Well, my short answer is preparation, preparation, preparation.
Yeah.
Make sure there's no surprises. If you prepare well, you have a plan. You have a plan A, but you also have a plan B, and you also have a plan C. And when it comes down to it, you have to be able to operate with fork and knife.
Yeah. Are you agree, Dr. Lloyd?
Yeah, I agree, but I have something more that I had the preparation to study to have planes A, B, C, but I had also Nick, and sometimes I answered Nick's questions I frequently had with a mail, with a phone call, and he resolved many of my troubles with his answers. So I agree with him.
That's also an important remark. That's also important that when you don't know it, then you have to ask someone else, and don't think that you are. I consult also John Kennedy or James Calder when I have a difficult case, or Beat Hinterman. I also have my peers, and when I'm uncertain about something which is just at the border, when it's about a tumor, I consult my tumor orthopedic surgeon. So it's important to realize that you cannot know everything, and that when you have doubts, that you ask someone in your group first, maybe, or someone outside your group, someone outside, but within your scope. But I also get that's why on Ankle Platform I also have this case submission, and I get cases from surgeons who have a problem from all over the world who ask my advice, because I realize that this is really important, because every patient is unique, and you cannot read everything in the literature. So I think what is your limits?
Absolutely. So it's important to have a network. But there is another question about it. So you are a prolific author. You wrote many papers, many books, chapters, and you create an ankle foot ankle school. And I remember in your courses, many famous colleagues spoke during your lessons, like Professor Golano, that I want to thank him for his contribution with his wonderful dissection, and very famous all over the world. And the question is, in my opinion, for success is important to have a great team. How did you build it, Professor Van Dijk?
Well, basically it is all it's all human work, and everybody is important in an organization. The doorman, laboratory worker, the nurses, the volunteers. So I believe it is very important to know them by name and to talk with them and make them feel that they are important and that their role in the organization is important and contributes to the success of the department. And also at the end of the day, in the surgery room, thank everybody that worked with you, the nurses, the anesthesiologists. I believe that if everybody in the organization feels himself important and be seen, that's how you build a team, and that's the key to success, I believe.
Okay. Yeah. Dr. Lloyd?
My team has been a Nick's team, the Alpha's team. I felt I was the Italian brother of the Dutch group of Nick, because they are beautiful guys, and I remember that during some dinners in Amsterdam or in London or abroad, all the members of the Dutch group spoke English among each other in order to let me understand. And I have never forgotten this thing. Because I really felt myself as a part of the team of the Dutch group of Nick. And when I wrote the cadaveric study on posterior arthroscopy with the technique of Nick, I went with my notes to Nick and to his group to discuss that if this was a good thing to publish or not, because I repeat, I felt as a part of a team, and Gino sometimes spoke to me in Italian also, but they were always very kindly and very friendly with me, so I felt a part of the group.
Yeah. So the next question you just answered about the real value of teaching. You answer, so we can step in the next in the third step. So we talk about your success, Professor Van Dijk. You treated many famous players. I remember one Monday, the Monday afternoon surgery at MSC, when you visit soccer players from every part of the world. I was enthusiastic because I met many famous players. And I remember one day when we were sat in the cafeteria close to your OR, and I asked you, how do you feel before operator Cristiano Ronaldo? And you told me, Albert, it's not easy. You can't make a mistake. And the question is, how has your professional life changed after this success and all this scientific recognition?
Well, maybe first to the value of teaching, because I think this is everything is about teaching. So just very short to go back. But I believe that in the teaching, it is very important to build up self-confidence. So for a resident, and you get self-confidence when you give the resident responsibility. So as a teacher, you need to give your resident responsibility in order to build up self-confidence. And you need to give positive feedback. It's important to make a compliment now and then, not just to mention what he should improve, but mention what went well. I believe that that is important, and that's what I wanted to add. And then to your question, what has changed after all in my career? Well, the more I learned and the more I studied, the more I realized that there is even more that we don't know. So it is important to stay modest, and of course it's important to study the literature and to realize that that you're updated. But on the other hand, the patient in front of you, whether it's a soccer player or whether it's a normal non-soccer player, someone who doesn't play sport, the patient in front of you is unique and doesn't always follow the literature. And the communication with the patient is key. That is sometimes more easy with normal patients than with professional soccer players, because they have also a physiotherapist and a club doctor, and they are doing the discussion, and maybe the soccer player is on his iPhone, and he is just looking at his iPhone and not answering the question because the physiotherapist is answering the question. So the communication with a professional soccer player not always is easy in that sense. But what is important with every patient to build up confidence with you have to build up a relation with your patient. I think that is vital.
Yes. Is the same for you, Dr. Dijk?
Yes, it's the same. It's really the same. That I think that the real thing is like Nick said, that they are the professional player, the professional jumper, the professional tennis player is the same. The same patient of a normal patient, but around the athletes are the problems, are the physiotherapist that sometimes is too aggressive, the manager that sometimes is especially interested in times in dollars or euros, in other things that then in the well-staying of the athletes. And I think that it's very, very important to have this feeling with the athletes. Is a person who have some special request, but there is a person, and many times the athletes are more fair of their condition, and so many times you have to encourage them and to sustain them. And for me is not it's grateful to treat an athletes, but it's not my first job.
Okay, we are reaching the end of the interview, so I want to know what do you think about the future, your opinion about the future of the surgery. I'm curious, what do you think about regenerative medicine, the micro instability? Today we talk a lot about microstability. Is it real or not? And what do you think about deltoid ligament or synostosis syndrome? Yeah, I know that there are many topics, but if you can tell me something about a brief thought about.
Well, let's start with micro instability.
Yeah, I know.
and I will have a nice in Milano, Esca. I will have a nice symposium for 1 hour. And micro instability, of course, it exists, like micro swelling or micro headache or micro giving way, of course, or micro pain in your stomach. But it doesn't mean you have to treat it. And I think that is the problem with all those new diagnoses. I'm always afraid of over-treatment, because micro instability, like I say, it will exist like everything in micro disbalance or whatever, but it just doesn't need treatment. So it is good that it is studied and that maybe it will lead to something, but first it has to be proven that it leads to a better results than having a non-operative approach. It is like PRP. How many studies have been done to go to regenerative medicine? It is there already for the 20, 25, 30 years being studied, and there's more evidence that it works. And a lot of these studies are industry driven. So you have to be very careful reading literature to see if regenerative medicine, it's good that it's there. It's good that research is being done, and it is the future, but it will take many years before we can make hyaline cartilage, for example. We are not there yet, and we have been studying it already for more than 30 years. Deltoid ligament disease, of course it will exist, but it is also a sort of new diagnosis, again, over treatment, because medial instability. Let me say it like this: impingement of the hip. Huh? I mean, it now a new diagnosis that exists 20 years. For many centuries,
yeah,
we didn't treat it. There was no problem. So maybe it's there, and it will be there, but not to the extent that it's being done now. It's like rotator cuff in the shoulder. You know, there's too many rotator cuffs being treated nowadays. And you know what happened in Finland? In Finland, arthroscopy of the shoulder is not reimbursed because there's so much misuse. It is the same as with arthroscopy for degenerative knee. It was misused in the US, and now we have abandoned it. We have to end that in ankle. This also will occur. So yes, it's good that there is research being done, microinstability, deltoid ligament disease, but we have to take care to implement it in our daily practice.
Yes, I think that there are new frontiers. Yes, I think yes, in the ankle. I agree with Nick with the regenerative medicine. I don't want to repeat what he told before. I think that is not a point, especially for the ankle, but it's a general problem. It's a general something to study more about. Ligaments in the ankle is not a new frontier. Is today it's already a good practice with many particular application. The deltoid ligament, yes, I think that will be a point of study, because for me, in arthroscopy, deltoid ligament is not so simple to approach, and I see also a new frontier for the subtalar joint, and especially for the sinus tarsi endoscopy that I performed in some cases with unexpected results, really unexpected, and so perhaps will be a new frontier of this kind of a field of a new frontier in this kind of surgery.
Yeah. So the bell is ringing, so we are at the end of the interview. So the last is not question, but I want to I ask you if you could give an advice for who wants approach to the endoscope, and one or two advice, please.
First of all, study the anatomy. Know where the nerves and vessels are. Start with easy cases. So for anterior arthroscopy, start with the soft tissue impingement or removal of small osteophytes. And for a posterior, start with a small ostrigonum. And for any surgery, preparation, preparation, preparation. This is for how to do it, but why to do it is as important as how to do it. Indication, indication, indication. So my single key message is listen to the patient. The patient is always right. Treat the patient, don't treat the MRI.
Thank you, Prof. Dr. Lioi.
Yes, I agree in every phrase, in every sentences of Nick, and the message is study, 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 and stay to hear what the patient say, and visit him without the watch the watch on the table, because you have to have time to stay with the patient and to visit the patient, and if it's possible, have a teacher with you for some kind of patients, of difficult patients.
Okay, so we are at the end of the interview. Many thanks for your precious time. I'm very lucky because I had the possibility to interview two of my teachers. I advise to every young colleagues to travel a lot around the world, to stay close to stay close to great surgeons for improving own skills. And I want to close this interview with what Steve Jobs said: "Stay hungry, stay foolish," because it's really important for me and for, I think, everybody. So thank you, Professor Van Dijk. Grazie, Dr. Lioi. È stato a very pleasure. And I hope to see as soon as possible. Zappa.
Thank you very much. Grazie.
Grazie a te, a voi. Ciao.
Grazie.
Ciao.
Arrivederci a tutti.
Arrivederci.
Grazie, prof.